Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to try to bring a few things together to help people understand a little bit more of what some of the rationale for taking the approach to osteopathy that I take. Now, the approach that I take is what I'd call a heuristic-based approach, or an approach that has a set of steps, a set of decisions that allows one to generate possible solutions to test between, as opposed to a set of steps that guarantees a solution. The rationale there is that humans are different than one another, and even different from themselves one moment to the next in some way that maybe isn't immediately identifiable. So if you have a set of steps that guarantees a solution, then it would be hard to figure out if the solution isn't the appropriate one or the most appropriate one. So if you think about something like an algorithm-based system, especially a social media system, if you think about whatever social media system you want to think about that you like, there will be a lot of recommendations, something like a search page, a For You page, watch this next, sort of like that, regardless of which thing it is that's using an algorithmic approach. If you consider, there are definitely times when you feel like it's giving you stuff that you appreciate, but also sometimes it tries to give you a recommendation and you're like, yeah, I definitely didn't want that. So the differentiation between the algorithm working and the algorithm not working for you as an individual within the same system is a simple example of where an algorithm may fall short. But a heuristic-based approach, or a set of steps that generates possible solutions to test between, is a more appropriate approach conceptually for humans because they're different than one another, as I already noted, and they can be different from themselves in one situation to the next, one moment to the next. So we've got that fundamental challenge. So we take a heuristic-based approach. Now, that heuristic-based approach is more properly underpinned or more appropriately talked about if we speak about something like far transfer. So near transfer being essentially the ability to learn a set of steps and apply that set of steps, detail-oriented steps, in slightly dissimilar situations. So one room to the next room is an easy way to talk about it. So you learn it in school, and then you go to a clinic room, and those are different, but the set of steps is the same. That's an algorithm-based approach. It's step by step by step. Here's the solution. A heuristic-based approach would be more appropriately mapped to far transfer. Far transfer is not the set of steps as such. It is a non-tangible thing. It's abstract. It's always there. It's the same in all circumstances, but because you can't touch it, you can't see it, you can't smell it, it's harder to kind of get to. It's described as a causal plot in a story, problem-solving approach, problem-solving scheme, something like that. So how you solve the problem. Now, you could say that there are steps to how you solve a problem, but because the details that anybody would observe are different enough that they may not be able to track it, that's where you start to get into that more abstract, more far transfer approach. So it's the thing that's always there, but it looks different, right? It's always there, it's always the same, but it looks different. Now, describing that because it's a little bit more abstract is tough, right? That's why we use a heuristic-based approach. It's essentially a choice-making approach. And built into that approach are the choices that one would meaningfully make when approaching the interaction between them and somebody who's presenting for some form of treatment, right? So they have some form of complaint and you're going to interact with them, but you've got to figure out what to do for them in that moment. So the center of that is how they respond to what you do. How they respond to what you do is the thing that lets you figure out when you're testing between your possible solutions if it's the most appropriate solution in that moment, because they'll either respond the way you want them to or not. Okay, so we've got a decision-making framework and some explanation of the rationale for that, that people are different than one another and different from themselves moment to moment. Now, if we start to consider that I take a more abstract approach to the profession, I don't talk as much about structures, I talk more about movements. The reason I talk more about movements happens to be the environment of observation of the professional or the practitioner or the hands-on individual. There's different ways to say it. So oftentimes you'll find me trying to say things different ways just because I know that not everybody is going to be grabbed by the same set of words. So I give you multiple angles with the words that I use to try to describe it so that you can stimulus pair a little bit better. You've got a broader network of meaning and maybe one of those hits you right. So you've got the practitioner trying to figure out what the heck to do. They need to have something to measure against. If you measure against the thoughts in your head of a structure doing this or a structure doing that, or a physiological process doing this or that, or a sensation that only the patient can feel doing this or that, you end up running into a problem because you can't observe it. So we have to acknowledge that we're outside the patient. We have to acknowledge that the thing that we're observing is motion. It either moves compared to its pair or it doesn't. It either squishes as a soft tissue compared to its region or it doesn't. Right? So it either looks like this, arm all the way up, arm not all the way up. For those listening, left arm went all the way up, right arm didn't. Or it looks like both arms go all the way up. If it doesn't look like that, then you know that there's some degree of difference. You may not know exactly why, but now you have the opportunity to have a set of behaviors that should restore motion to the right arm that's not moving as well, as long as you pay attention to how the patient responds. The barrier concept is the thing that sets osteopathy apart, because the way that I say it is don't make them say ouch. Don't make them say ouch is essentially a quick rule of thumb, a quick heuristic to pay attention to not making the patient protect themselves. The patient protecting themselves will appear as active contraction to pull away from whatever it is you're doing, even a slow contraction to protect and not allow you to move the patient in the way that you're trying to move the patient. It could be a sound, an abrupt sound. Now, it may not be ouch. It may not be that hurts. It just may be an abrupt sound. It could be like a grunt, something of that nature, or an abrupt facial expression. So you have no choice when you're interacting with a patient to use all of the senses that you as a practitioner have available to you, because there may be a practitioner who can see and feel and not hear. There may be a practitioner who can feel and hear but not see, right? So there may be some degree to which senses are not fully available to each practitioner, and that's fine because those people will find a way around it. But it's a multi-sensory experience. There's multiple senses that come together to allow you to monitor the patient to see if they're protecting themselves with respect to what you're doing. There's vision, there's palpation or haptic feedback. So vision, seeing something happen, palpation, feeling some resistance, feeling some pull away, and then audition or the auditory sense, hearing some form of abrupt sound in relation to whatever you're doing. So now we have the responsibility of the perception of the practitioner to tell them whether or not the patient is protecting themselves, okay? So we've got decision points that require the senses. My argument happens to be that the most appropriate description, not the absolute reality, but the most appropriate description of how you should be doing osteopathy or doing any hands-on practice is what you'd call bottom-up, so sensory first. What are you sensing? And it's not one sense, it's multiple senses. It's at minimum, if it's all available to you, vision, hearing, and touch, right? That's all got to come together in some way, shape, or form to be able to monitor. So the argument is that it's more appropriately discussed as bottom-up. It doesn't function that way because people don't function that way. Practitioners don't function that way. Practitioners are going to map senses to previous experiences and think about it that way. Now, depending on how somebody teaches you what to think, you are going to be primed, or you could say you have a preference, you could say you have a bias. Now, biases and preferences are different. Preferences, you know that you like something more than another thing. A bias is a mistaken thinking that you don't know you're making. The manner in which somebody teaches you to integrate what you think and what you feel is going to prime you to go in a particular direction. Now, the problem that you run into is if that's not most appropriate to solve the problem that the individual presenting for treatment is giving you, then you're going to miss it. Now, coming back again a little bit, you're outside the patient. You only have certain information. You cannot feel what they feel. So the argument that I often make, or the discussion that I'll have, is signs versus symptoms. Signs are something that everybody can identify, including the patient. So asymmetrical motion, either gross motion or soft tissue yields to pressure, those are things that can be identified by anybody. The sensation, the internal sensation, the pain sensation, the uncomfortable sensation cannot be sensed by the practitioner. They can gather proxy information as to whether or not they're in the neighborhood of things that are uncomfortable, because the information that I've already talked about, being an abrupt face, an abrupt movement, an abrupt sound in relation to whatever the practitioner happens to be generating as motion between them and the patient, that is a proxy for some internal sensation. It isn't the internal sensation itself, and it can be misinterpreted. You can be wrong. A patient can protect themselves for a lot of reasons. It may not be a noxious stimulus, it may not be a painful stimulus, but it's protection nonetheless. If you can avoid generating protective responses, then you are probably on the right track, using the barrier concept appropriately. So we've got a lot of things at play. We've got bottom-up processing, we've got top-down processing, how you think about stuff. If I tell you something very specific to think about in relation to whatever you palpate, then that primes you to think that way and miss other things. So this is where we get to start to bring a few other pieces of information together. So if we look at the theory of constructed emotion that I've spoken about before, Dr. Lisa Feldman Barrett putting that forth as the primary. Lots of other people would have helped Dr. Barrett, but she's the one that has presented the theory of constructed emotion. Essentially, the body has a large amount of sensory surfaces. That information gets fed up, so it's bottom up. It then gets interpreted in the brain based on previous experience. When that occurs, it seems to be mostly because predicting what's going to happen is less expensive metabolically than responding in the moment. So it is easier to predict and just do what you predict than it is to pay attention in the moment and respond to what's actually happening. So learning is more costly than repeating, something of that nature, or that would be an example. So we now, if what Dr. Barrett suggests in all of her very large amount of work, that the sensory surfaces of the body are wide, that the interpretation ends up narrowing how you respond because it's less metabolically expensive, then we have something that neurologically maps relatively well to the experience, or not the experience, the process of observing a novice versus observing an expert. A novice can sense everything, but they don't necessarily know what to do with it. So the novice sin seems to be a little bit more the sin of interpretation. They just don't know what to think about it or what to do. Whereas the sin of the expert is learning what not to do. So the sin of the expert is the sin of omission. So if you consistently solve a problem with a particular approach, then you learn that that's the approach that works. So you learn not to do other approaches. So you omit things. If the particular instance that you're interfacing with a particular patient requires something that you wouldn't normally do, and you're an expert, you've omitted it. So it's the sin of omission. You could map that relatively well to prediction, right? So you predict that it's going to be this thing. So you get things in diagnostic literature like premature closure, but it's because it is more effective to predict than to respond, or more efficient to predict than to respond. So we know that we have that problem. If we teach you to narrow down at the start as opposed to go through the process and learn fairly consistently that your error is the error of omission, that it's where you didn't look as opposed to what you normally succeed with, then we let you go from all kinds of information, narrow down to prediction, and just stick with that prediction. There's another term called experience utility that describes using the same thing over and over again and maybe not even knowing that it didn't work, not detecting that it didn't work. So that's from cognitive bias literature. So we see the process, the neurological process of interpreting with previous information. We see that describing relatively well novice to expert. We see that in cognitive bias literature, mistakes that you don't know you're making with respect to thinking, that if I succeeded with this thing before, I'll do it again, right? So those map relatively well together. When things from different lines of evidence map well together, you call it consilience, or it has been called consilience. They just come together relatively well. So we've got the theory of constructed emotion, expertise models, or expertise observations, and observations of cognitive errors seeming to come together. So if we train you to have a process by which you purposely omit things in your assessment, We narrow your assessment down, and you know that you narrowed your assessment down because you learned how to do all kinds of assessments, and then you made your own that gives you the majority of the information that you would want to be able to go and interact with a person. And then if you don't find anything in the tests that you normally do, you have a bunch of other tests, and you know that for sure. So we're able to sort of meet the novice and the expert somewhere in the middle, because we want the expert to know that they're not doing things, because they know as a novice, or they learn as a novice, that there is a bunch of things to do. So I want it front of mind as often as possible. You're not doing certain things on purpose. And if you're not finding something, you easily can go into the things that you're not doing on purpose. So it's omission on purpose as opposed to omission by accident through experienced utility, right? So we've got that. Now, if we think about why I talk about going to sign rather than symptom, if you look at the current pain science classifications, or classifications of pain that seem to at least broadly create constructs that are separate enough that we can properly investigate them, where maybe we didn't do that as well before, or maybe the scientific endeavor didn't do it as well as it could have before. So we've got nociceptive pain, which includes possible or actual damage to tissue, which is appropriately sensed by free nerve endings, or not free nerve endings, by nociceptive nerve endings, goes up to the brain, gets interpreted. The interpretation can vary highly within the same individual, but we at least know that if we examine tissue, we'll find something. Now, that is probably the category that any hands-on practitioner is going to interact with properly, because they can find possible or actual damage to tissue, and they can do something about it, especially if you're a hands-on practitioner, you're outside the person. The movement is either appropriate in relation to that possible or actual damage to tissue, or the movement is inappropriate, right? So if it's not appropriate, you interact with it in a consistent, reliable way without making the patient say, ouch. You get a positive general range of outcomes. There you go. Then we have neuropathic pain. So if you examine tissue, there's not really anything wrong with the tissue, but if you examine the nerve, there's something wrong with the nerve. Now, it's very rare that a hands-on practitioner is going to be able to do that properly. You're going to need a deeper diagnostic, which is not really available from the outside of the patient with just your hands, your eyes, and your ears. But with extended sensory technology, or extended sensor technology that most MDs would have available to them, especially neurologists, you can get a little closer to that and figure out if there is something going on with a nerve. Now, maybe you can't find that, so there's no actual or possible damage to tissue, there's no neuropathology. Then what you have left is what we are now calling, or what is now being called, nociplastic pain. So it is the report of pain, or the experience of pain, with the lack of possible or actual tissue damage, and with a lack of identifiable neural pathology. So we now have this new category. That's probably the place that hands-on practitioners are going to have the least success. It's not impossible to have success with neurological pathologies with hands-on, but you wouldn't know as well as you would know, or have a way to sense as well, if you have what would be properly mapped to neuropathic pain, or sorry, nociceptive pain. So nociceptive pain, easy to find, or easiest to find for hands-on practitioners. Neuropathic pain, harder. Nociplastic pain, well, it's just a report, you're not going to find it. Now, regardless of which type of pain it is, it's basically impossible to truly sense that outside of the patient. Movement is there. So if we're to maybe make a prediction as to where hands-on practitioners are going to have a real impact, it's appropriately identifiable nociceptive pain. Less so neuropathic, and probably very, very random results with nociplastic pain. Now, some would argue that because nociplastic pain isn't related to the tissues, then a hands-on interface or a therapeutic interface is probably going to do a lot. And maybe it will, but I think that the normal variance in people would predictably suggest that you'd have normally variable ranges of outcomes. Or maybe, and those normally variable ranges of outcomes would not necessarily be positively valenced or directed in the way that the patient would be wanting and looking for. So, okay, we've got normal processes for going from novice to expert, normal processes for deleting things. We want to be careful about that because it's a normal sin. So if we can engineer for it by using heuristic-based frameworks or choice-based frameworks, that are always there, but the details vary, then we may be onto something. If we tell you that we want you looking for movement, not pain, then you're probably going to be in a more appropriate place to succeed as somebody who's working from outside of the individual who presents for some form of treatment that you have skills for. It's probably more so a nociceptive pain type situation, or nociceptive discomfort, or just a mechanical issue with no discomfort, right? Now, we then wrap this up a little bit and look at something that we've already talked about, a paper that we've already talked about. So we see all these things come together in the observation from a paper I talked about from the International Journal of Osteopathic Medicine, where they took, I believe it was first-year students. I may be wrong about the year, but they took some early osteopathic students. They taught them about the normal rate, or what they claimed in different conditions as the normal rate of the pulsation of cerebrospinal fluid per minute. And whatever rate that they told the students, that is the rate within a very, very reliable range that was reported back. The range, if I remember right, when students were not taught about a particular frequency of pulsation of cerebrospinal fluid, the range was larger and it wasn't as consistent, such that maybe that's where you'd find the people observing what they thought was the pulsation of the CSF. But when you tell them the number, they anchor to that number because you've narrowed their interpretation. So you've essentially given them the opportunity to offload the observation, right? They go top down as opposed to bottom up. I think it's going to be reasonably well argued that going bottom up is important, or maybe making that what you pay more attention to than thinking about what's inside or what you're feeling or interpreting, because you can easily overinterpret and interpret wrong. So that's the novice to the expert. You can interpret wrong and not know it because you can still have success with the methods. That then underpins why I say osteopathy does good work but has crazy stories. Right? So all of this, if you've listened this far, thank you. But all of this comes together to say, if you're trying to teach somebody something and you cannot detect the error, you will then go through a regular sort of cultural reproduction process. But if you're trying to scratch at what you're saying and you just start to detect some of the errors and you start to detect, hey, maybe I don't know if that's the vagus nerve. Maybe I don't know if that's the psoas, because I've seen dissections and touching the psoas from the outside of the body is essentially impossible. Maybe I don't know if that's the QL because the QL lives in front of the erector mass and thoracolumbar fascia. So even to get to it, I'd be behind the patient and come right in on their flanks. And to do that, I'd probably cause a lot of damage. Maybe it isn't their QL. Maybe I can't palpate their QL. Maybe I can't palpate these smaller muscles that I know for sure are deep to superficial muscles and fatty tissue and all these things. So instead of paying attention to the structure, maybe I pay attention to the movement. And if I teach them to look for the movement that's the problem, then they're observing the thing that they have access to, as opposed to trying to interpret the thing that they don't have access to. So the moment you go under the observable realm, you have no choice but to make more assumptions. We want to make as few assumptions as possible. Even with what I'm saying, there's probably assumptions that I have made that I can't detect. But if I acknowledge that and I think that, then when information comes up that should point me in that direction, I can probably start to get towards it. But if I say I'm right, if I say this is definitely me palpating cerebrospinal fluid, if I say that this is definitely me palpating the movement of a particular organ, if I say that this is definitely a quantum phenomenon, then I have prematurely closed my ability to interact with it because I can't observe on those levels. Unfortunately, if you like physics, I'm best described as a classical mechanics being, so trying to interpret with the senses that I know that I have available to me, and at the best level that I can use those together, multisensory integration, keep your hands and your eyes on the prize as the heuristic. Eyes and hands on the prize means pay attention to what you're doing, try to see it, and try to feel it to the best of your ability, because feeling and seeing give you different pieces of information that make you understand better when you use them both. So instead of leaning into the way that you were taught, which is normal, and the stories that you were taught with, maybe attempt to examine them and see if There's information out there that tells you that those stories have a problem. If those stories have a problem, consider not using them. Consider trying from first principles to develop an approach. I'm highly motivated to say, consider doing and saying the things that I'm saying, but that violates what I think is important. What I think is important is the attempt to acknowledge that you have biases, you have preferences, you make errors, but find as many of them as you can. Try to minimize them in how you're approaching, because the person that presents for some form of treatment is the end user of your skills. They are not there to reinforce your belief. They're not there to reinforce your ideas. They are there to have some notable change. The notable change that you're most likely to have is in the physical realm, because that's how you're interacting with them. Other stuff is happening, but it's not your skill set. It's not your specialty. It's not your expertise. So using a more abstract and less detail-ridden story probably allows you to pay attention to them more, and using a more heuristic-based approach, or an approach that will generate a set of possible solutions to test between, and knowing that the test results that you're looking for is they don't say ouch, aka they don't protect themselves, and it moves better. So it either yields better as soft tissue to pressure, or it moves better in a gross mechanical sense. So the limb moves better, the big movement works better. So you have things to test against. So obviously, I have reason to believe that from first principles, I'm on the right track, but I have to acknowledge that there's probably some errors in the things that I'm saying. I would encourage you to try to work that way, especially if you're an osteopathic educator or a hands-on educator in any field, in any practice, such as massage therapy, such as physiotherapy, such as chiropractic, whatever you're doing. Maybe reconsider the stories. Maybe tell people how to behave with less of the stories, right? Because realistically, we're all interfacing with somebody who presents in the physical realm outside of what they can feel. So we need to rely on something. If we rely on movement, we're probably as accurate as we're going to be with the senses we have available to us. So hopefully you learned something from that, or hopefully you went through the journey of synthesizing a bunch of lines of evidence to further underpin and explain why I take the approach that I take. So hopefully that was useful to you, and we'll talk again soon.